We'll move on to our grand rounds today. It's our second last grand rounds of the academic year, and I am really excited about the topic. This is something that was actually born out of previous COVID based grand rounds that we did with Dr. Lewanczuk, where we recognized that there is so much more out there in terms of the impact of illness on patients that is outside of the illness itself and related really to social determinants. And over the last 15 months that I've been in this position, I've had the opportunity to work with various individuals that have this similar interest, and Richard and Karen have formed an alliance to sort of move this forward between individuals that have an interest. All of us deal with chronic disease, and of course, in Karen's area of public health and preventive medicine. So with that, we'll get started. The topic for today is how social factors impact our patients' health and our ability to provide care across divisional experience. I'm just going to introduce the primary moderators, and then they will introduce the rest of the panel. So Dr. Karen Lee is Associate Professor in the Division of Preventive Medicine in our Department of Medicine. She is an AHS Medical Officer of Health with Provincial Public Health and Population Health and author of the book Fit Cities. She also teaches at the University of Alberta School of Urban and Regional Planning and at Columbia University in New York. She currently directs the Housing for Health initiative at the University of Alberta with over 200 multi-sector partners from across Canada and Quebec, including Quebec, collaborating to improve housing developments and their surrounding community environments to support health and well-being, particularly physical activity, healthy food access, and social connections. And then, of course, Dr. Richard Lewanczuk is professor in the Division of Endocrinology and Metabolism. He's also the Senior Medical Director for Primary Healthcare for Alberta Health Services from its inception until January of 2019. Since then, his role has evolved to become the Senior Medical Director for Health System Integration, which is AHS's long-term vision for integration within the healthcare system, as well across sectors which determine health, such as volunteer sector, other government ministries, municipalities, and business, all with the goal of keeping people as healthy, well, and independent as they can be in their homes. Prior to the formation of AHS, Dr. Lewanczuk was Medical Director for Chronic Disease Management in the previous Capital Health Authority, and he's been involved with chronic disease management and prevention for most of his career and has contributed to many national and international bodies and initiatives which address either specific chronic diseases, chronic disease in general, or health system integration. So with that, I will hand it over to Drs. Karen Lee and Richard Lewanczuk.
Morning, everyone. Thanks very much, Norman, and welcome to all of you. We're really excited about these rounds. This is going to be a really unique set of rounds. As Norman mentioned, we became, very aware of all of the impact of social factors on our patients, on their illnesses, and on our ability to provide care. So rather than the traditional whole bunch of slides and a lecture type of grand rounds, we thought we'd really put together some anecdotes, some stories, some personalized experiences about the effect of social determinants on our patients and on our ability to provide care. And so we put out a call. As mentioned, we have a little bit of a working group that started meeting in the last year around this. And we had a number of people volunteer, but we spread things across divisions. So we have Dr. Meena Kalluri from Division of Pulmonary Medicine, Dr. Bibiana Cujec from Cardiology, Dr. Stan Houston from Infectious Disease, and Dr. Tammy McNab from Endocrinology, all of whom have prepared their anecdotes. And huge thanks to Andrea Cliff, who has sewn together all of the anecdotes, a little bit of background that both myself and Karen will provide around this topic, just so that we can make it as seamless as possible. The other thing is we're going to involve you as well. We're going to start off with a couple polling questions. We'll then have a very short presentation from myself, pre-recorded, and then I'll hand things over to Karen, and she'll follow up with some polling questions, short presentation from her. Then we'll see the anecdotes, and then we'll have full panel discussion and comments, questions from all of you. So we'll get going with the first polling question then, if we could. And the first question is, what is the approximate annual income below which people are considered to be living in poverty in Canada? So you can see the responses there: 12,000, 18,000, 24, 28, or $40,000 annual income. We'll give you a few seconds to provide your responses. And there's the responses, a little bit over the map, but settling around the 24,000. The actual answer is $40,000. Based on Statistics Canada, this can actually be higher in cities like Toronto and such, where housing costs are high. You can see here listed that $40,000 is the poverty line. If you're working full-time at minimum wage in Alberta, you're going to be way below the poverty line. And so it's not surprising that many people have to work 2 or 3 jobs to earn a sufficient income to meet their needs. So we'll go on to the next question. Is people are considered to have housing insecurity when what percentage of their monthly household income is used for housing? Is it 20, 30, 50, or 70% of their monthly income being assigned to housing? And there's the answers. You can see most people chose 50%. The actual answer is 30%. So over 30% of your monthly income for housing is considered to be housing insecurity. Turns out that 40% of renters in Alberta are already paying more than 30% of their monthly income on rent. Some research one of our colleagues in Department of Family Medicine is carrying out, Dr. Denise Campbell-Shears, actually showing that housing insecurity is one of the major determinants of other problems. So if people are paying 70% of their monthly income for rent, it means they have no money left over for food or adequate food. So housing insecurity leads to food insecurity, for example, or they can't afford internet. And of course, how much of what we do and are required to do is required to be done by computer and such. So with that, we'll stop the polling questions and move on to the first presentation. Hi, I'm Richard Lewanczuk, and I'd like to talk to you about the role of social determinants in health. One of the things that we know is that healthcare occupies the largest proportion of the Alberta or any provincial budget. And of healthcare budgets, we know that hospitalization is the single biggest line item, which leads us to the question of who is being admitted to hospital and why are they being admitted to hospital. So when we ask this question and we go to the data people, what they do is they typically give us a list of diseases. People are being admitted to hospital for heart failure, COPD, diabetes. And then our typical response is, okay, well then we need more COPD and heart failure and diabetes clinics, and nothing changes. Hospitalization rates continue to go up. And so then we go back and ask the question of, well, maybe if we could identify individuals who are going to be hospitalized or at risk, we could predict, maybe we could get ahead of the game and prevent them from being hospitalized. And so we did that. We took our medical administrative data and we ran it through the computer. And if you know anything about receiver operated curves, you'll see that this is a fancy diagram saying that the answer was no. We could not predict who was going to be admitted to hospital. And then we thought some more and we wondered, maybe we don't have the right data, or maybe we don't have all of the data. So we went and got some other data and we put that into the computer, and lo and behold, all of a sudden we were able to predict with a fair degree of accuracy who was likely to be hospitalized in the next year. Well, it turns out that this other data happened to be social data. And of the social data, in this case, it turned out to be the UCLA loneliness score that was the single greatest predictor of hospitalization in seniors. But we could have substituted income or food security or housing security and would have got just about as good a predictive ability. But this shouldn't surprise us because at the same time we had been doing a qualitative study on hospitalization, and when we did the study, it didn't matter the biggest, the smallest hospitals in the province. What we heard time and time again when we asked the question about why was this person admitted to hospital, we would hear stories like, well, medically maybe we could have managed, but what? But I couldn't send them home. But there was nobody to look after them. But if I sent them home, we'd get them right back. What they were really saying and what we were really hearing was that the resources necessary to manage people at home really didn't exist, weren't known, or weren't coordinated. And more often than not, it was actually the social factors. But this shouldn't surprise us because way back in 2002, Health Canada told us that about 75% of health and wellness was actually determined by the social situation and social factors. Commonwealth Fund told us exactly the same thing. 80% of health and wellness determined by social factors and our built and living environments. And not that long ago, 2017, Deloitte in the United States looked at hospitalization and again said 80% of the attributable cause of hospitalization was social, not medical. So going back to Alberta data, we plotted hospitalization rates in all of the local geographic areas versus age of the population in that area. So the older the population, the more likely there would be hospitalizations. And indeed, we found a statistically, although I would say not clinically significant correlation between the age of the local population and the hospitalization rates. But then we swapped out age, and what we did was we swapped in the income level in that geographic area. And lo and behold, much tighter correlation and predictability for hospitalization. Again, underscoring that it was the social situation that was tending to drive hospitalization. Or to put it another way, the hospital was the default for social problems. Or another way, we were trying to solve social problems with an emergency department and a hospital. Well, this is a map of the city of Edmonton, and every single dot is a complex high-need patient. And I think you have a sense of what a complex high-need patient might be. In this case, if you recall what that previous map looked like, and now look at diabetes prevalence, although this could be hypertension, heart failure, or COPD prevalence, you find that they all superimpose prevalence of chronic disease and prevalence of high needs or high cost patients. And if you look in the top left panel now, and if you look at material deprivation or poverty levels, you can see again the same sort of superimposition that chronic disease, high cost, high needs patients superimposes with poverty or other social factors. And I don't have a granular enough map for just Edmonton, but now if you look at access to primary care or primary care continuity, exactly the same thing. So this superimposition. So our tendency is to blame people and say, well, first of all, you should be seeing your family doctor. It's your fault. The fact that there actually aren't family doctors in these areas, or the same density at least, is sort of beside the point. But if you think about it, health is really not a priority for people who have no idea whether they're going to be evicted tomorrow, have food on their table tonight. So they don't care about what their 10-year Framingham risk score might be, or what their hemoglobin A1C is, or what their blood pressure is. They just need to survive. And so if we address their social needs, then maybe we can get back to paying attention to longer-term healthcare needs. Just as an example, if we look at food security and the correlation between food insecurity and chronic disease. So there's 6 chronic diseases listed here. Actually, these are the 6 most common and 6 most costly chronic conditions in Alberta, in Canada, in North America. And you can see a strong correlation between food insecurity and the prevalence of these diseases. And although you might say, well, that's a correlation, it turns out that if we actually address these social factors, that the disease levels do tend to go down. In Alberta, we looked at the risk of having diabetes out of control. And we put all our numbers into the computer and nothing came out. But then we put in social factors, in this case, income level. And again, magically, we all of a sudden could predict who would and who wouldn't have their diabetes controlled. But other groups such as Geisinger, a well-known care organization in the United States, looked at diabetes control, and what they found is that you got way more bang for your buck if you paid attention to people's food security than if you just gave them more pills. So what can we do about this in Alberta as a Department of Medicine? Well, first of all, if we don't know about it and don't ask about it, then we can't do anything about it. And so you might note, or maybe you haven't noted, bottom left-hand corner of Connect Care, the front page lists the social determinants of health and how many of us have asked our patients for a check to see if these factors have been looked at. I can tell you that if you're admitted to hospital at Massachusetts General Hospital or Brigham and Women's Hospital in Boston, first thing they do is they ask you about your social supports. They ask you about interpersonal violence. Do you have stable housing? Do you have transportation? Do you have food security? Do you have a job? Can you pay your utilities? And they found there that they get 100 times more return on investment by addressing social factors than all of the high-tech gadgets they put in place over the last 10 years. And so what has been found is that if we do address social factors and the social determinants, indeed the things that we look at as measures such as emergency department visit rates, hospitalization rates, length of stays, all go down. Not that those are our end goals. Those are measures of if we provide care to our patients in its broadest form, then we don't default to the emergency department or the hospital as the source of care. So I'll finish there and hand over to my colleague, Dr. Karen Lee.
Thank you, Richard. I'm Dr. Karen Lee, and I'm in the Division of Prevention, which is also in the Department of Medicine here at U of A. And I'm going to take over from where Richard left off and talk a little bit more about additional determinants of health, as well as evidence-based solutions to addressing some of these determinants of health. So in particular, I'm going to talk about improving community environments for health. So, according to the Public Health Agency of Canada, there are 12 determinants of health. Income and social status, social support networks, education and literacy, employment and working conditions, our social environments, our physical environments, our physical health practices and coping skills, healthy child development. Then, of course, there's biology and genetics, health services, gender, and culture. I think very often we focus on health services as a determinant of health. We may talk about genetics or things that we think cannot be changed. But in fact, as you can see, many of these items in green are actually things that are modifiable by human actions. Just to let you guys know, I currently direct a project called Housing for Health at the University of Alberta. And it does have a partnership working group and subcommittees of over 200 multi-sector partners, including urban planners, folks who are working in recreation, folks from food services, and we are actually collectively working together on a set of healthy community guidelines that we hope will be coming out later this year or early next year. And they span even partners outside of Alberta. Anyways, just to let you guys know this, in case you're interested, please do contact me after this meeting, and we'd love to have you as part of our partnership working group. We have two pilot developments, housing developments, one in Edmonton and one in Whitecourt, where we're trying to pilot what might be feasible in the Alberta context for improving housing developments and the neighborhoods around them, for supporting active living, healthy eating, and social connections. There's a whole community engagement component because, of course, if our community members and residents are not interested in these issues, then there will be less support politically and also less industry demand for changes in practices of how we develop our housing developments and neighborhoods. We're, of course, doing research and evaluation on the impacts of these various initiatives. And we also have an annual conference called Fit Cities, Fit Towns Canada, Hopefully some of you can join February of 2022 if you weren't able to join in February of 2021 at our first annual conference. So I wanted to talk about some of the evidence-based solutions to improving these many determinants of health. Everything from healthy behaviors to improving social connections to even sources of crime, such as sources of stress, such as crime in communities. So community design actually matters. So, where we have different types of housing that allow for enough people to live in a neighborhood or community area, you can then actually place stores, jobs, schools, recreation facilities, and other amenities close to them because there's enough people to support it. And connecting these people to, these amenities from their homes by good sidewalks, good pedestrian paths, safe street crossings, are all actually really important components. If our environment is also safe, so you can actually walk, because there's enough lighting in the winter time. So safe from both crime as well as traffic. There's aesthetic appeal, like good landscaping. And these things can be shaped by zoning regulations, by building codes, by builders' practices, government policies. Studies show an association with a over 160% median improvement in physical activity. Also, increased sense of community and decreased isolation. So more people walking around often results in you running into your neighbor rather than being socially isolated. And then also associations with reduced crime and stress. So more eyes on the streets are often good for safety on the streets. Building design can also matter. So for example, a very available opportunity in everyday life in our buildings where we spend the vast majority of our time today include promotion of stair use and availability of amenities for promoting stair use. So simple signage reminding people in their busy lives to use the stairs for health and other benefits can actually improve stair use by a median of 50%. Skip-stop elevators, so very high-rise buildings, can actually reprogram the elevators so that most elevators, except for the one being required by people who might have disabilities or carrying large loads, can actually be reprogrammed to stop at every third or fourth floor. Design and aesthetic interventions that make stairs convenient, accessible, and also pleasant to use actually do matter as well. Food environments matter. So for example, if you live in a food desert neighborhood that has no healthy food, so supermarkets are not present, farmers markets are not present, lack of supermarket availability is associated with higher rates of neighborhood obesity and poor dietary outcomes. Conversely, living in a food swamp where you're surrounded by a lot of unhealthy foods, such as fast food restaurants, that is associated with increased obesity as well as poorer dietary intakes in both adults and children. There are also things we can do within food retail. For example, labeling on menus, like putting calories and sodium warnings in restaurant menus have been shown to be associated with better outcomes amongst people who want to use them, and good acceptability amongst the public. There are also things we could do within restaurant foods, like removal of trans fats that can matter in restaurant and cafeteria foods. Social support mechanisms can be used to concurrently strengthen physical activity outcomes as well as social outcomes. So interventions that strengthen social networks around healthy behaviors like physical activity, buddy activities, walking groups, groups that provide friendship but focused on physically active activities have associated outcomes not only for socialization but also increased physical activity. And even having community health workers that support chronic disease patients have been shown to be associated with improvements in blood pressure, cholesterol, triglycerides, blood sugar control. And then worksite factors that matter. I think we often think about information and education, but in fact, physical and organizational structures at work either make healthy choices easier or difficult, and they do matter a lot. And so these comprehensive types of interventions beyond education and information are really key. And other work factors, I think Richard had already mentioned income, but additionally to that, work insecurity matters a lot. Stress at work, in other words, having low control at your job, low social supports. If you have a high effort job that's poorly rewarded, those are risk factors in multiple studies for both mental and physical health problems. Now, just to end with, saying that prior to coming back to Edmonton, I was in New York City working for Mayor Bloomberg's administration in the health department in New York for New York City. I was there for nearly a decade. I was in New York for 12 years working on these issues. And, in under a decade of concerted efforts with health, partnering with sectors outside of health to make improvements to our community environments, to our determinants of health, that within less than a decade, we were able to reverse childhood obesity trends, while, many other cities and places were seeing continued rise. No physical activity in the last 30 days showed significant decline after no change in the previous decade. And within less than a decade, we were able to improve life expectancies so that it increased at faster rates beyond the US. And when analyses were done, this was shown to be in large part due to improved chronic disease outcomes. Anyways, these are documented in a book called Fit Cities for those who might be interested in reading more about them. There are also some courses for those who are interested. Faculty of Extension recently did a half-day webinar with me, and we anticipate offering that in future years as well. And if you're interested ever, not this June, but in future years, to come to New York City and spend a couple of days there, there's also a course called Designing Healthy Cities. My website also has resources if you're interested. So thank you very much. That concludes my portion of the presentation. But we're now going to actually move on to a distinguished panel of 4 panelists, all from the Department of Medicine and different divisions. So first, we're going to have Dr. Bibiana Cujec from the Division of Cardiology. She'll be followed by Dr. Meena Kalluri from the Division of Pulmonary Medicine. Then we will have Dr. Tammy McNab from the Division of Endocrinology and Metabolism. And finally, Dr. Stan Houston from the Division of Infectious Diseases. So I'm going to pass it on now to Bibiana.
Hello, I'm Bibiana Cujec. I'm a cardiologist here at the Masankowski Alberta Heart Institute, and I would like to share Paul's story with you. Paul was 32 years old when he developed heart failure, reduced ejection fraction, secondary to alcohol, cocaine, and methamphetamine use. He was a carpenter, but was unable to work because of these addictions. He was in and out of prison during the first 2 years after his heart failure diagnosis. During his time in prison, his heart failure invariably improved with adherence to sacubitril valsartan, bisoprolol, furosemide, and spironolactone. However, whenever he was released from prison, he would sleep outdoors and was unable to afford his medications. To buy food, he would strip wires in abandoned buildings and sell the copper. Paul had a wife and a 3-year-old son. Paul's parents were raising his son, but would not allow Paul's wife to live in their home. After a few days of living outdoors, Paul would inevitably end up in the emergency room with acute decompensation of heart failure, receive IV furosemide, and be sent back to us in the heart function clinic. Over the 4 years that we followed him, in addition to homelessness and hunger, we also were challenged to contact him, as he did not have a cell phone, and we had to communicate through his mother. Our nurses consulted the cardiac rehabilitation social worker to facilitate Paul's application for Alberta Works, so at least his heart failure medications were covered, and he received $700 per month. With this, Paul was able to rent a home and live with his wife and some other friends. He could not get H as he had not filed taxes for several years. At one clinic visit, Paul had diffuse skin ulcerations, which the ID specialist diagnosed as Staph aureus furunculosis. He recommended bleach baths, a simple, affordable treatment that allowed healing of his ulcers and made a huge difference to Paul's quality of life. Over time, Paul had progression of heart failure, and his mother started accompanying him to clinic visits. As he was being assessed for potential LVAD, he died suddenly at the age of 36. With Paul, our biggest struggle was ensuring that his basic needs of food, shelter, and communication were met. Social worker involvement was essential to meet these, as well as his medical needs. It is a sobering fact that his heart failure was better managed when he was in prison. COVID-19 has exposed the profound inequities within our society. In cardiology, we are working towards the development of a social worker-administered contingency fund to provide for bridge medications, transportation, housing, and meals for needy outpatients or the families of inpatients. This is one small step. We need to think of many more and take them. Thank you.
Hi, everyone. My name is Meena Kalluri. I'm a respirologist with an interest in interstitial lung disease. And over the past decade or so, I've been working towards building a patient-centered practice and have developed an interest in social determinants of health. I would like to share an ILD case with you today and reflect on the impact of social determinants of health in this particular case. So we met Mr. M about 3 years ago in our ILD practice. He was 59 at that time and lived a fairly active lifestyle. He was newly diagnosed with myositis and ILD, and that's how he came to our clinic. We started treatment. His disease progressed through 2019. He had progressive shortness of breath, decline in function, always reported anxiety, and had associated weight loss that we attributed to his underlying disease. In the same year, he had 2 more hospitalizations. Comes back to clinic in 2020. We escalate treatment, identify new medical problems for which he cannot afford medical treatment. He continues to have progressive decline. In that year, he also has another hospitalization. So over the span of about 3 years, he's been seen by 6 different specialists, 5 different teams during hospitalizations, and including a home care team. Unfortunately, his condition continued to deteriorate. He went from being an active man to wheelchair bound and had several unmet needs that came to light when we applied the social determinants of health lens to this situation. And this is what it revealed. So he had been struggling since 2018 with disability that led to loss of job, which brought in tremendous economic instability. So for him, this was fairly new, and it precipitated a lot of stress, anxiety, isolation from his family members, which I suspect contributed to his hospitalizations through immunosuppression that can happen with stress and malnutrition. In addition, when he became wheelchair bound, he had housing concerns that added to further his anxiety and mental health status. This also had a profound impact on his care, as he could not afford to buy the expendables for the newer therapies that we were prescribing, and I suspect food insecurity had set in at that point, resulting in poor choices, which I suspect would have added to hospitalization, which was essentially for volume overload. So finally, in 2021, through the use of a multidisciplinary team, as well as sensitive history taking, we were able to identify food insecurity, and he was finally able to admit that he had been struggling with food and just oxygen to breathe through a lot of shame and guilt that was associated with it. And it came to light that perhaps these situations were also affecting his function and his shortness of breath profoundly. So the team went about addressing it. We called the food bank in his area. And when the food bank was informed, they were very willing to put up a hamper for him. We provided them instructions so that he was given appropriate dietary material and food. And we arranged a pickup time for his spouse. And lo and behold, 4 months later, when we followed up with the patient, He appeared cheerful, less anxious, and to our surprise, he reported subjective improvement in his dyspnea and function. And for the very first time, he actually reported being hopeful. And this came as a very pleasant surprise to us that such a simple intervention like addressing food insecurity and providing him the needed supports could have such a meaningful impact on his quality of life. Even though this gentleman had access to medical care, specialists, hospitalization, and expensive immunosuppressive drugs, in the end, we felt that it was prioritizing social diagnosis and addressing his needs through effective teamwork and providing access to supports was what made the biggest difference and created a deep and meaningful impact for this gentleman and his family. Thank you.
Hi, my name is Dr. Tammy McNab, and I'm an endocrinologist in the Division of Endocrinology and Metabolism at the University of Alberta. My practice is largely centered around diabetes, primarily type 1, complex type 2, and gestational diabetes. And I'm happy to share with you some of the impacts of social determinants of health on patients in my patient population. So patients with diabetes actually are really common in terms of struggling with their health care, struggling with an ability to achieve target glucose control. And in a Diabetes Canada survey, 57% of patients don't comply with their diabetes treatment plan due to the cost of medications and treatment. That doesn't include time off of work. It doesn't include time to visit, attend appointments, transportation to and from, childcare. It doesn't actually even really include meal planning and food costs. It doesn't consider housing security and all of the other factors that one needs in order to be able to look after diabetes. Canadians with diabetes pay up to a third of their annual income to manage their diabetes, and it's more if you have more complex issues or complications, or if you have type 1 diabetes. The cost of basic diabetes self-management in type 1 is up to $5,200 annually, and that's not including patients who are on insulin pump therapy, which is a lot more expensive, adding at least $2,000 a year. And for type 2, it's up to $2,800 annually just to look after diabetes. And this also excludes the attendance at visits, missing work, and all of those other hidden costs that are really important to the patient. Lots of patients have made statements to me throughout my career, and I thought I'd just gather some of the statements I had in clinic in the last month or two. So this is from a single mom working full-time, trying to make ends meet, and she told me, I don't test my glucose as often as I should to ration strips for my daughter with type 1 diabetes. She couldn't afford to pay for strips for both, and so she was basically giving that care angle to her daughter. A second patient, a first-time pregnant mother-to-be with newly diagnosed gestational diabetes, was found to be limiting food, basically starving to try and achieve target glucose. And she said she couldn't afford insulin to treat her gestational diabetes. She was having trouble affording the glucose test strips that we needed for her 4 times daily tests. And she found the diet was expensive as well. So she was trying to limit this in order to achieve target control so that her baby would be well. And we know that diabetes in pregnancy, if it's not well managed, has a longer term impact on the baby and future generations, increasing the risk of diabetes and obesity and other potential complications that will trickle down into the future. Another young man with 3 part-time jobs, no benefits, trying to make ends meet, living with roommates, doesn't own his own apartment. And he said, I can't test my glucose at work or I'll lose my job. Now, we would like to think that human rights would intervene here, but many employers don't have good accessibility resources or offices like that to help. And patients really feel that they are put on the spot if they're at all different. They might not get as many shifts, they might not be asked back, or people might look for reasons to terminate their employment. Another patient recently admitted for a below-the-knee amputation, hadn't attended diabetes education, hadn't been very attentive to his care because he wasn't able to leave work in order to attend the day-and-a-half or 2-day standard classes that we have for our patients. Also wasn't able to leave work to attend appointments, and so was really struggling to manage correctly, and said he tried to learn about diabetes online because he couldn't afford to take time off to attend diabetes classes. I have another patient who's 84 years old, used to be an avid skier, also is an avid rose gardener and a really interesting lady, very engaged, but very limited financially, and recently had a below-the-knee amputation, which probably could have avoided, but she couldn't really afford to test as often. And she asked me recently, how long do I have to test 4 times a day? These test strips are pricey. This is someone who's lost their leg, very keen to maintain good care, but certainly can't afford what is considered ideal. So those are just some examples of things that we deal with every day in the diabetes clinic. And I think overall, we think we have universal healthcare in Canada, but the reality is that we maybe have universal access to urgent and emergent care. We have universal access to doctor visits, but the actual treatment that we're needed, especially in the case of diabetes, to maintain health, to prevent complications, we don't have universal access to that. And equity is definitely badly needed.
Hi, I'm Stan Houston from the Division of Infectious Disease, also from the Division of General and Internal Medicine, the School of Public Health, and former director of the Northern Alberta HIV program. I'm going to try and bring an ID perspective to this topic. No disclosures that are relevant today. So I think we've all seen a list of social determinants of health. I think the question is to what degree we really apply this to our day-to-day work in clinical care and our other Department of Medicine activities. This is just to remind us of the extraordinary correlation between, in this case, life expectancy, and even more obviously, disability-free life expectancy, and indicators of poverty and deprivation. So there's an extraordinarily strong correlation between just about every major disease and disease group and the social determinants of health, with very few exceptions. But this correlation is even stronger for communicable diseases. We're all familiar with TB as a quintessential disease of poverty and marginalization. Obviously, diarrheal disease is associated with poor socioeconomic conditions. I'm going to touch on HIV. And we're recently learning of the disproportionate impact of COVID-19 on some populations. I'm going to use HIV as an example because more than half of our patients belong to these groups, Indigenous and immigrant or refugee people who bear a disproportionate burden of the negative impacts of social determinants of health. So it's pretty easy to think of some of the effects on our Indigenous patients, and perhaps even more, refugees share some of the same issues, but with some additional. I want to highlight our responsibility, not just as clinicians and teachers, but as citizens and advocates in relation to social policies, social, economic, and political policies that affect the upstream social determinants of health, as well as our role on a day-to-day basis in the wards and in the clinics, but also in our teaching and research.
Thank you to the panel and to those, I think, very touching stories that also have, a lot of relevance to our healthcare systems. We're going to move on now, to a more open discussion. But before we do that, we have a couple of more polling questions for you. So I'm going to share my screen now, and I think Andrea is also going to put the polls up now. So the first one is, what % of Alberta's population is affected by food insecurity and potential inability to afford fruits and vegetables? So the poll is open now. So a lot of folks said 18%. The answer, 13%. So, if you look at food insecurity across different provinces in Alberta, including Alberta, about 12.9% of Alberta's population is estimated to suffer from food insecurity. Do you routinely ask your patients if they have difficulty affording their medications? And as you can see, the percentage of people who cannot afford their prescriptions by drug class actually run across drug classes. But I think more folks still, we have 55% who ask these questions. And so there are still more of us who could be asking this more routinely as well. Okay, with that, I'm going to turn it over to Narman to actually moderate the Q&A live session of the panel now. Narman?
Thanks. Thank you, Karen. Thank you, everybody. That was really powerful and I think very eye-opening. So I'm actually going to start off myself before we go to the official Q&A, and I'm going to throw this one at Tammy. Tammy, you mentioned, I think it was really poignant the way you said, yes, we have a universal healthcare system, but doesn't mean that we provide universal healthcare. So, as clinicians, patients do get in the door to see us, either in clinic or in the hospital. What is it that we can do to address the social determinants of health in our practices?
I think the very first thing we need to do is ask how our own clinics, our clinic structure, even our accessibility may be impacting patients participating in care. I think that's one of the simplest things we could start with. I think it's obvious now, hopefully to everyone, to ask the questions, and you can't tell by looking at the patient in front of you whether or not there are factors impacting them. I actually spoke to a lady yesterday who's a university professor who was a sessional lecturer who lost her job and told me yesterday she's trying to decide, can she afford her medications? Can she afford food? Can she keep her home? And it's not a situation that I anticipated. And certainly she's lucky she has a home and she has something she could sell. But putting ourselves in that situation, that would be really difficult. And then we have people who obviously have a lot of challenges, like the patients presented today, who don't have homes and who do better if they're incarcerated or in a situation, for example, where they're admitted. I've actually really noticed that with the pandemic and having more phone visits, all phone visits practically, that many of my patients are attending visits more regularly. They're more prepared. They're not having to leave work. They can step away for 15 minutes and have a conversation. And it's been really revolutionary, I think. I've even had one patient, the one I presented, who went for the below-the-knee amputation but couldn't go for education. His story is actually much more involved than that, and that's just a minor issue. But his A1C went from 15.7% down to 6% because he could take 15 minutes away, have a brief conversation with me, and I broke up these usually long, lengthy visits that we used to have historically into tiny little nuggets that actually fit into his life and didn't interfere with his income and his ability to work, pay for things. So I think we could all look at how we do practice and did practice and how our clinics are set up and make some changes there.
Thanks, Tammy. That's really helpful. I'm going to throw this one at Bibiana. There's a question about pharma companies and whether or not, you're seeing more and more coming on board with compassionate care medications. I mean, especially in your specialty and maybe in Meena's to a certain extent, we see these expensive drugs that are out there and patients unable to afford them. Do you have any thoughts about that?
Oh, yes. We have no trouble getting the expensive drugs, like Entresto, for example, or the SGLT2 inhibitors. We get samples, we get compassionate release of those drugs, but we can't get antihypertensive medications that have been on the market for a while, or ACE inhibitors, beta blockers, especially. We can only get the most expensive recently released drugs from pharma. And I've contacted pharmaceutical representatives in the past to ask for antihypertensive medications, and they don't have any programs for that kind of compassionate release.
And diuretics.
Yeah, diuretics, definitely not.
Meena?
Hi. So I just wanted to chime in and pretty much echo what Bibiana was saying. In my practice, I find often that most of these expensive immunosuppressive medications can be easily obtained through the STED process that Alberta Health has in place. But for my patients who are hypoxemic, just getting them enough oxygen early enough in their course so that it has an actual impact on their symptoms, their function, and their quality of life has been an ongoing challenge. And I suspect in the case that I presented, the patient choosing to pay for his oxygen over his food might have led to more instability. So I do think there needs to be more work done, perhaps outside of the health sector. And in this particular case, it was building relationships outside of the health sector, so meeting with private companies and trying to get more funding for these patients so that they can at least have oxygen to breathe. So that's what I think my approach within my field has taught me, that we need to be stepping outside of just the usual medical relationships or these collaborations that we have, and try and step out and thinking more laterally and differently out of the box. And that is what has been the most eye-opening thing that has literally revolutionized the patient's life, when they can actually function and have access to oxygen and access to physio and better quality of life in that process.
Stan, I see you have your hand up.
Yeah, well, we should remember that Medicare got its start because Tommy Douglas felt that, as hopefully most of you know, he had charitable treatment by a surgeon that saved his leg from osteomyelitis and allowed him to go on to become a boxer and a minister and a politician. But his fundamental principle was that healthcare should not depend on charity. And so if we're depending on charity from pharma, that's a fundamental rejection of the basic principle of Medicare, and we need a better solution than that. And we've been kind of focused on the socioeconomic challenges of people who already have advanced medical problems, many of which were actually caused by problems with their determinants of health, such as diabetes and diet and so on. So we shouldn't forget about the upstream issues of social determinants of health preventing much of these problems we're talking about.
Richard, could I ask you to pipe in about 211? I think that is the most important thing I ever learned about was 211.
Sure. So probably everybody's thinking, well, what can we do? If we ask about it, then what? If somebody does have food insecurity or housing problems, the one thing you can do is you can have the person contact her on their behalf. You can just dial 211 anywhere in the province. You can text, you can email 211, and they will match the person's need, assess the person's need, and match them with available resource, again, anywhere in the province. Doesn't matter whether it's Edmonton, Calgary, or the most remote rural areas. We work really, really closely with them. And they even have the capacity to case manage some of the more difficult people. So they will check. It's not just, well, here's a phone number, for the food bank. They will actually connect people directly in real time to that resource. And then they will check back in a few days saying, did you get your need met? So that's one thing that we can do as we try and put all of these other things like social prescribing into place.
And I can tell you it works because I've used it a few times. I'm not going to ask any of the questions around the politics of all of this. I can tell you that Richard is involved at multiple levels in terms of advocating and getting the message out. We're very fortunate to have him, in his role with Alberta Health and within AHS. But the last question I'm going to throw to you, Karen, asking about the private sector and home builders in Alberta, particularly related to preventive measures that Stan just talked about. Can you comment on that before we end?
Yeah, absolutely. I think what I'm hearing, from the panel is, the need to think about both shorter and immediate term solutions, right? So there are things potentially there are partnerships with pharma, but they're not the long-term solution as Stan was saying, but they can provide potentially some immediate solutions. that we're faced with. Richard talked about, and you did as well, about 211 and, the services that are out there. Now, one of the issues, of course, is improving connections to available services. But sometimes the services are also faced with issues like people need more affordable housing, but there's a lack of sufficiently built affordable housing. So if that's the case, we have to move even further upstream to address those issues. So we might link people to transportation services that they might need to access. But if there's a lack of transportation or public transportation services, then these upstream determinants like transportation access, housing access, those are things that we can also address from both a policy and a non-healthcare sector practice. What that requires, of course, as you've identified, Norman, is partnerships with both public and private sector entities outside of healthcare that can shape that. So, developers. There are, for example, right now, CMHC, Canadian Mortgage and Housing Corporation of Canada, actually has incentives for people to build more mixed income housing. So you could get, low interest rate loans if you incorporate affordable units, for example, into what is generally more of a market rate type of housing. So there are opportunities to work with, developers, but also municipal and provincial policymakers, Ministry of Seniors and Housing in City of Edmonton, for example.
Thank you. Karen, I'm sorry, it's 9 o'clock, so I have to cut you off. Sorry about that. Thank you so much for, you've obviously gotten a taste of this. We feel really strongly that the Department of Medicine needs to lead this work in identifying that this is an important component of what we need to be addressing for our patients. So to that end, you heard at the beginning that a small working group has already been formed, and we want to continue to build and develop momentum. There is a direction that we need to go, and we need all the folks within the department to participate and help us pave that direction. So if you're interested, please get in touch with Richard and Karen. There is going to be more to come. We're not just tantalizing your taste buds with this information. We are planning to move forward with solutions and identify a way forward. So with that, I'd like to thank everybody on the panel, to Richard and Karen for leading this work, and to all of you for participating. Take care. Have a wonderful Friday.